80% of AI projects never move beyond pilot. 95% of AI initiatives fail to deliver a return on investment. Hospital leaders report repeated pilot failures and persistent difficulty evaluating vendor performance before contracts are signed. The hype is real, the results are not. And the gap is not a technology problem, it is a decision-making issue. I'm Chris, 20 years in healthcare, the last decade in cloud and AI. I'm the healthcare architect. In this video, I am breaking down 5 learnings from a closed-door session between 12 health systems and 6 AI developers. You will learn why your AI portfolio is probably misaligned, why prioritization is the hardest discipline your team will practice, and exactly what to do about it this quarter. Let me give you the blunt truth about why most health system AI investments stall. The Digital Medicine Society and Qualified Health convened leaders from 12 health systems and 6 AI developers for a closed-door working session on how AI decisions are being made, implemented, and evaluated in practice. The agenda was simple. How are AI decisions actually being made, implemented, and evaluated inside health systems today? What emerged was a pattern I see constantly in my own work with health systems. AI investments are not anchored to enterprise strategy. They follow vendor activity, peer adoption, or internal demand. A vendor launches a new product. A peer system announces an AI partnership. A department head asks for a pilot. The investment gets approved, but nobody asks the basic question: does this move us toward a defined goal? In academic medical centers, this misalignment is especially visible. These systems balance care delivery, research, and education, each with different incentives and different timelines. Add in financial performance pressures, and you have a recipe for AI portfolios that expand without a coherent rationale. Individual use cases may be defensible on their own. Collectively, they do not move the system toward anything. The result is a growing portfolio of pilots with no clear path to scale. That is the first failure mode. The second failure mode is even more common. Prioritization is treated as a one-time decision rather than an ongoing operating discipline. Requests for AI solutions pour in from every direction. Executives want measurable impact on access, cost, and workforce performance. Frontline clinicians want AI to reduce burden and improve workflows. Operational leaders want to address bottlenecks. Each request is legitimate. Taken together, they exceed the system's capacity to act. And the typical response is to approve all of them. That is how you end up with a portfolio full of pilots and zero-scale solutions. Per Rand Corporation, more than 80% of AI projects fail, roughly double the rate of non-AI IT projects. MIT's Nanda initiative found 95% of enterprise generative AI pilots deliver zero measurable ROI. Prioritization requires trade-offs that most leadership teams avoid. Saying yes to one use case means delaying or declining others. So instead, everything gets a pilot. Nothing gets finished. Here is what the systems that are actually delivering results have figured out. They define a small number of enterprise priorities and use them as an anchor for every AI decision. Not a list of 50 use cases. Not a vendor-driven roadmap. 2 or 3 clear strategic anchors. Improving access, stabilizing margins, addressing workforce constraints. Those are the ones I hear most often from systems that are making progress. These priorities do 2 things. First, they determine which use cases get pursued. If an AI proposal does not tie to one of those anchors, it does not move forward. Second, they determine how success is measured. A pilot without a predefined metric is not a pilot. It is an experiment you will never learn from. The systems that are delivering results also treat prioritization as a recurring discipline, not a one-time event. Once resources are committed and workflows are redesigned, it becomes politically difficult to reverse course, so they build in formal checkpoints. What is working? What is not? Does this still tie to an enterprise anchor? Should we stop this and reallocate? Early success is most often reported in 4 areas. Revenue cycle management, where AI coding and billing automation is a $450 million market. Ambient clinical documentation, now at $600 million in annual spend. Referral management, and targeted clinical workflows in areas like cardiology. Some systems are also demonstrating measurable impact by improving access through reduced backlogs and expanded capacity. Now let me give you 2 operational realities that most articles skip over. First, the source of funding shapes behavior. Centrally funded initiatives are more likely to align with enterprise priorities because someone at the top is holding the line. Department-driven efforts can move more quickly but often do not scale because nobody is coordinating across silos. Both approaches have a role, but without coordination, they work at cross purposes. Second, foundational readiness is not optional. Systems that are making progress have established baseline capabilities across workforce training, operational processes, and data exchange. Without that foundation, even the best chosen use cases struggle to deliver sustained results. You cannot build AI on broken workflows. This pattern is not unique to healthcare. In financial services, Deloitte's 2024 AI adoption report found only 38% of AI projects meet or exceed ROI expectations, with over 60% of firms reporting significant implementation delays. Banking faces the same structural gap between pilot enthusiasm and production discipline that health systems face. The industries that close this gap fastest will define the next decade of operational performance. Here are the 5 learnings from that session as an actionable framework you can apply this week. Learning 1: anchor AI decisions to enterprise priorities. Not vendor roadmaps, not peer activity, not internal enthusiasm. Strategic alignment is the only thing that keeps your portfolio coherent. Learning 2: prioritize ruthlessly. Say yes to 2 or 3 things, say no to everything else. Build checkpoints into every pilot so you can stop what is not working before sunk costs make it impossible to exit. Learning 3: match funding to strategy. Centralized funding drives enterprise alignment. Department funding drives speed. Use both deliberately, not accidentally. Learning 4: build the foundation before you scale. Workforce training, operational processes, data exchange. These are not optional prerequisites. They are the infrastructure your AI runs on. Learning 5: treat this as a discipline, not a project. The systems that are winning are running ongoing operating processes. They review their portfolios quarterly. They stop failing pilots without hesitation. They reallocate resources to what is working. Here is what I want you to take away. The AI ambition gap is not a technology gap. Your vendors are not failing you because their models are not good enough. They are failing you because your decision-making infrastructure was not built for this. You have the framework now. Pick 2 or 3 enterprise anchors. Hold every AI investment against them. Build quarterly review checkpoints so you can stop what is not working and scale what is. The systems that are delivering results did not get there by doing more, they got there by doing fewer things better. That is the competitive advantage in healthcare AI right now. I'm the healthcare architect. See you in the next one.